Hi everyone, I am Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that you can recall faster and more quickly in your exams. In today's session, we are going to break down the anatomy of palm into clear, high-yielding, exam-focused concepts. So let's get started. So in the palm, we are going to just cover the main important exam-related concepts. That's it. So we're not going to details of all the anatomical features of the palm. So the first important structure in the palm which you have to know is the flexor retinaculum. So retinaculum is nothing but a modification of the deep fascia, right? So it is a fibrous band which we see, which is present mainly to hold all the tendons which are, that is the flexor tendons, which are going from the flexor compartment of the forearm to the palm. So it holds all these tendons in place so that there is no bowstringing. So during the flexion movements at the wrist, there is no bowstringing of these tendons. So to prevent that, we have this fibrous band. So this band, it bridges the anterior concavity which is formed by the carpal bones. Okay. So and it forms this tunnel which we call it as the carpal tunnel. Now this flexor retinaculum is rectangular . Okay, and when we see, it is attached medially to the pisiform. Okay, so medially it will be attached to the pisiform and hook of Hammett, and laterally it is attached to the tubercle of scaphoid. Tubercle of scaphoid and crest of trapezium. So what is important here is there are certain structures which pass above the retinaculum and few structures which pass beneath the retinaculum. So the tunnel formed here, we call it as the carpal tunnel. So we can see, so here the pisiform and so this is the crest of trapezium. And here we can see the pisiform. Okay, and the tubercle of the scaphoid will be here in this portion. Okay, so the structures passing above and below, when we say the structures which pass above here, okay, above the flexor retinaculum from medial to lateral. Okay, when we have to remember the structures passing from medial to lateral above the retinaculum when we see. Okay, so here we have to remember it as, you can remember as NAP at 3, NAP at 3 or P3. Okay. Okay, or you can also remember it as NAP at 3. So what is that now? N is for ulnar nerve, ulnar artery, Palmar cutaneous branch of ulnar nerve, branch of ulnar nerve. This is the palmaris longus tendon. Okay, and here we have the Palmar cutaneous branch of median nerve. Median nerve. Okay, so these are the structures from medial to lateral which pass above the retinaculum and enter the palm. So structures passing beneath the retinaculum, okay, deep to the flexor retinaculum, mainly there is only one nerve here, that is the median nerve. Then we have the tendons of flexor digitorum superficialis, then the tendons of flexor digitorum profundus, then flexor pollicis longus, and we also have the tendon of, this is the flexor pollicis longus and the tendon of external flexor carpi radialis. So these are the tendons and the median nerve which pass beneath the flexor retinaculum through the carpal tunnel. Then coming to the intrinsic muscles of the palm. So we will just look at which are the intrinsic muscles of the palm and what are their main actions. So first we have the intrinsic muscles. There are about 20 intrinsic muscles. Okay, and the intrinsic muscles include the thenar, the hypothenar, the lumbricals. We have the palmar and dorsal interossei and adductor pollicis. So these form the intrinsic muscles. So now here what we see, three muscles here. These are the thenar muscles. So which are the thenar muscles? So thenar muscles form the thenar eminence. Okay, and these thenar muscles include the flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis. So as the name says, they bring about the actions. That is the flexion of the thumb, abduction of the thumb, and opposition of the thumb. So these are the movements brought about by the thenar muscles. And which is the nerve supplying these thenar muscles? It is the recurrent branch of median nerve. So next, moving on to the hypothenar muscles. So the hypothenar muscles include the, here we see two muscles here. So the two muscles seen here are, we can see the abductor, digiti minimi, and the flexor digiti minimi. And the other muscle includes the opponens. So all these muscles, they are supplied by the hypothenar muscles are supplied by the deep branch of ulnar nerve. Then we have the adductor pollicis. Okay, so adductor pollicis has two heads, an oblique head and a transverse head. Two heads, and this brings about, the adductor pollicis brings about the adduction of the thumb. Okay, so by an oblique and a transverse. So this is the oblique head and this is the transverse head. So this brings about the adduction of the thumb. So this muscle is supplied by the ulnar nerve. Okay, so the deep branch of ulnar nerve ends by supplying the adductor. It is supplied by deep branch of ulnar nerve. So usually we test this muscle by what we call it as the Fomen's test. Okay, so adductor pollicis muscle. Next we have the lumbricals. So there are 4 lumbricals which from lateral to medial they are named as first, second, third and fourth. Okay, and these lumbricals, okay, what you have to know about it is they have the origin from the tendons of flexor digitorum profundus. Okay, so that is their origin, and what is their action. And another thing what you have to remember is the first and second lumbricals are unipinnate, the third and fourth are bipinnate. Okay, so first and second lumbricals, the first and second, they are supplied by median nerve, and the third and fourth, they are supplied by the deep branch of ulnar nerve. So what is their action? They flex. So they flex the 𝗕𝗏𝗄𝗡phalangeal joints. Okay, flex the 𝗕𝗏𝗄𝗡phalangeal. So that will be here. So they flex the 𝗕𝗏𝗄𝗡phalangeal joints between the metacarpal and the phalanges, and they extend. Okay, they will extend the interphalangeal, extend the interphalangeal, that is the proximal interpip and dip joints. Okay, proximal and distal interphalangeal joints. So that is the action of lumbricals. So here you can see this is the first and second, third and fourth, which are bipinnate. Okay, so first and second supplied by median, third and fourth supplied by the deep branch of ulnar nerve, and they bring about flexion of the metacarpophalangeal and extension of the interphalangeal joints, distal and the proximal. Next, we have the Palmar interossei muscle. So, Palmar interossei muscle, they are small muscles, basically 4 small muscles, and they are between the metacarpals. We will see them. Okay, the palmar surface of the metacarpals. So, they are also named 1 to 4 from the lateral to medial side. So, these palmar muscles, what is the action they bring about? Palmar interossei, remember pad. Okay, so palmar is adduction, and they are all supplied. Okay, the palmar interossei are supplied by the deep branch of ulnar nerve. So they bring about the adduction. Then we have the dorsal interossei muscle. So dorsal interossei muscle. So another thing before that, the palmar interossei are all unipennate. Okay, they are unipennate muscle. So if you see along the median axis, okay, so the middle finger, they do not have the attachment, they attach on either side. Okay, and the movement is towards the axis, central axis, that is towards the middle finger. Next we have the dorsal interossei. So the dorsal interossei dab. Okay, so dab, what is dab now? Dorsal will bring about abduction. So they are also supplied by the deep branch of ulnar nerve. So these muscles are bipinnate. So the nerves in the palm, okay, the main nerve supplying the palm, or the nerve of the palm, we call the ulnar as the nerve of the palm. Okay, so ulnar nerve is the nerve of the palm. In addition to that, we also see it is the main nerve, because this ulnar nerve supplies almost all the intrinsic muscles of the palm except for the thenar and first and second lumbricals. So only these muscles, they are supplied by the median nerve. Okay, so if we see the ulnar nerve and also sensory, when we look at the palm, the ulnar nerve will be supplying the sensory supply will be the medial third of the palm plus skin over the medial 1.5 fingers. Okay, it will be supplying the little and the half of ring finger. Whereas the median nerve, so this is the ulnar. So median nerve will be supplying lateral 3/4, okay, lateral 2/3 or 3/4 you can say, as well as of the palm, plus 3.5 fingers laterally. Okay. So same thing on the dorsal side also, it will be supplying the median nerve. Will be dorsal side, it is the radial nerve down here, but the up to the nail bed. Okay, the radial nerve will be supplying only up to the nail bed. So the nail bed region, the distal phalanx region, is supplied by the median nerve for the lateral 3.5 digits, but ulnar nerve supplies both the dorsal aspects as well as the ventral aspect, that is the palmar aspect of the hand. Okay, so palmar aspect as well as the dorsal aspect of the hand is supplied by ulnar nerve on the medial 1/3. Right. So that is about the nerves there. So median nerve in the hand, if you see, so it gives the palmar cutaneous branch. Okay, and this palmar cutaneous branch will be passing. So palmar cutaneous branch will pass above. So if you see the median nerve, the palmar cutaneous branch will pass above the flexor retinaculum. Okay, this is the palmar cutaneous branch, and it will be supplying the skin over the lateral 2/3 of the palm, as well as the lateral 2/3 of the palm. That is why its name is palmar cutaneous branch. Then once it enters, it divides into lateral and a medial branch. So this branch will give a recurrent. So this is the recurrent branch which will be supplying the thenar muscles, and here 2 lumbricals. Okay, first and second lumbricals. Then it will end by supplying the lateral 3.5 digits plus the nail bed region and the dorsal aspect. Okay, so that is the median nerve. When we see the ulnar nerve, so the ulnar nerve, before it enters the palm, okay, so ulnar nerve passes above the flexor retinaculum and enters the palm. So there it will give a dorsal branch, okay, dorsal cutaneous branch, which will be supplying the dorsal. So this is the dorsal branch, dorsal cutaneous branch, okay, which will be supplying the dorsal aspect of the skin over the palm, as well as the medial dorsal aspect of the skin over the dorsum of the hand, okay, or the medial aspect, as well as the medial 1.5 digits on its dorsal aspect it will be supplying, including the nail bed. Whereas the palmar branch, okay, so this is the palmar cutaneous branch. So palmar cutaneous branch, which will be supplying the medial 1/3 of the skin over the palm. Then once it enters the palm, okay, it will give a superficial branch. So this is the superficial branch. So superficial branch will supply one subcutaneous muscle, that is the palmaris brevis, and then it will supply the medial 1.5 skin over the medial 1.5 fingers here, okay, the little and the half of ring finger. Then it gives an articular branch to the wrist, that this is the deep branch. So this is the deep branch. So the deep branch will supply the hypothenar, the 3rd and 4th lumbricals, okay, lumbricals, all palmar interossei, all dorsal interossei, okay, all the 4 palmar, 4 dorsal interossei, and it will supply all the palmar interossei, all the dorsal interossei, and ends by supplying the adductor pollicis. So the blood supply to the palm is by the palmar arches. And the palmar arches, we have two. One is the superficial palmar arch and other one is the deep palmar arch. So what you have to know is what forms the superficial palmar arch and what forms the deep palmar arch. So if you see, this is the superficial palmar arch. And superficial palmar arch is mainly formed by the ulnar artery. Okay, so it is the direct continuation of ulnar artery. And it is contributed by three arteries. One is the superficial palmar branch of radial. This is the superficial palmar branch of radial. Then radialis indicis, this is the radialis indicis artery. Okay, and also the princeps pollicis artery. So this superficial palmar arch, it will be completed on the lateral side either by one of these. One is the superficial palmar branch of radial or radialis indicis artery, which supplies the lateral aspect of the index finger, and then princeps pollicis, which supplies the thumb. So it will be completed by these three branches of radial. Okay, branches of radial, either one of them. Then it gives three common. So if you see here, it gives three common digitals. So 1, 2, 3. This is the three common digital arteries. And these digital arteries, again, they divide at the interdigital cleft to supply the either side of the fingers. And it will give one proper digital. This is the proper digital artery. Okay, it gives, that goes to the medial aspect of the little finger. Then also, other than that, it also gives cutaneous supply to the palm. Then the deep palmar arch. Okay, so this is the deep palmar arch here. So the deep palmar arch, if you see, this is a direct continuation of radial. Okay, so the radial artery forms the deep palmar arch and it will be completed medially by the deep palmar. So here we have the deep palmar branch of ulnar. So this gives three palmar metacarpal arteries, okay, metacarpal arteries that will join the common digital artery here. You can see these are the metacarpal, okay, this one and this. So three palmar metacarpal. Then it gives three perforating arteries which will pass through this second, third and fourth interosseous spaces to anastomose with the dorsal metacarpal arteries. And it also gives recurrent branches. So that is about the palmar arches. So carpal tunnel syndrome. So carpal tunnel syndrome is basically because of here compression of the nerve, okay, the median nerve in the carpal tunnel can lead to pain, tingling sensation, numbness, all of that. Okay, and that is so basically there is compression of median nerve here. So this compression of the median nerve may be due to various causes like tenosynovitis, the myxedema, retention of fluid in pregnancy, or fracture dislocation of the scaphoid there. Okay, sorry, not scaphoid, the lunate bone. Okay, and then osteoarthritis of the breast. So tenosynovitis, myxedema, retention of fluid in pregnancy, then the fracture of lunate bone or osteoarthritis can lead to this carpal tunnel syndrome. So what will happen here? There is feeling of burning sensations. Okay, so there is burning sensation along the distribution of the burning pain, or it is also called as the pins and needles sensation, okay, along the distribution of the median nerve. So there is no loss of sensation over the thenar eminence because it is supplied by the palmar-cutaneous branch, right, before it enters the carpal tunnel. So there is no loss of sensation there. The weakness of thenar muscles is there, okay, and 𝗵𝗚𝗏 deformity. The typical deformity you will see will be the 𝗵𝗚𝗏 deformity. And if it is untreated, it can lead to paralysis of the thenar muscles. So the two signs are positive here. One is the positive Tinel sign. So this is the positive Tinel sign. So percussion over the flexor retinaculum will reproduce the symptoms of carpal tunnel. Okay, the patient's symptoms are exaggerated. Then this is the Tinel's. Okay, so this is known as the Tinel's sign. And then we have the Phalen's test. Okay, so Phalen's test, when we approximate both the joints, okay, the wrist joints together, then again there is exaggeration. Flexion of the both of wrist joints against each other will lead to exaggeration of the patient's symptoms. So this is known as the Phalen's test. So this is basically the test for adductor pollicis. So when we have to hold something like this, okay, so here we ask the patient to hold. So if the muscle is intact, the nerve supply is intact, then what happens? The patient is able to approximate the thumb, okay, to the index finger. But if not, then they hold it this way, okay. So this is normal, healthy. Okay, so what we do is we give the patient like a paper or something, okay, and ask them to hold it between the thumb and the index finger. So of both the hands. So if the muscle is healthy and acting normally, the thumb will be straight like this. Like you can see, it goes this way and it holds, okay. But if the muscle is paralyzed, the thumbs are flexed at the interphalangeal joint and they hold it this way, okay, flexed at the interphalangeal joint and they hold it like this. So that is when the adductors are not acting, okay. So that is the test we do and that we call it as the Fomen's test. So this is the Fomen's test. So this is basically done to test the adductor. So normally if the adductor is thing, we will hold it this way because there is adduction and we will hold it like this, okay. Thumb is straight and we can hold. But if it is paralyzed, then the adduction is not there. So when we are trying to hold, what happens? This will flex and try to hold it this way, okay. So that is Fomen's test positive. So the flexor muscle will be acting there, okay, compensating for the loss of adduction movements. Then we have the ulnar claw hand. So ulnar claw hand here, it is called the incomplete claw hand, okay, incomplete claw hand or false claw hand also they say, because there it's only the two fingers which are involved, that is the little and the ring finger, okay, that is ulnar claw hand. And okay, so this we call it as the incomplete claw hand. So ulnar nerve entrapment, okay, so the next condition, that is ulnar nerve entrapment, can occur in the ulnar, or it is also called as the ulnar canal or ulnar canal syndrome, otherwise called as Guyon's canal or Guyon's tunnel, okay. So this is a clinical condition when the ulnar nerve is compressed in this Guyon's canal. So it is basically formed by the 𝗖𝗏𝗧𝗏𝗏𝗧 ligament, okay, it's an osseofibrous canal formed by the 𝗖𝗏𝗧𝗏𝗏𝗧 ligament, which bridges the gap between the pisiform and the hook of the hamate. So here the nerve can be compressed and it leads to hypoesthesia in the, that is in the medial 1.5 fingers, and weakness of the intrinsic muscles, because the ulnar nerve supplies most of the intrinsic muscles of the palm. So usually the three nerves which we see here, wrist drop, we see in relation to radial nerve, okay, this is wrist drop, this is ulnar Now we see claw hand, partial claw hand. Okay, so there is flexion of the interphalangeal joints and extension here at the metacarpophalangeal joint and flexion at the interphalangeal, that is claw hand. Here in the median nerve we see the benediction sign. So they are the main signs in relation to the three nerves supplying the palm and the extensor tendons of the hand. Next we move on to the facial spaces. Okay, so facial spaces of hand is very important because they are the potential spaces which are basically filled with loose connective tissue, and if there is an infection can spread to this, as well as infection can happen within these spaces. Okay, so that is why it is very important to know. So usually pus fluid can get collected since they get easily infected. Now the various spaces which we see, we have the Palmar spaces. Palmar spaces. Okay, so Palmar spaces include the mid-palmar space here. So this is the mid-palmar. Mid-palmar space, and this space here we call it as the Thenar space. Okay, so we see two spaces, the Palmar, the mid-palmar and the Thenar space. Then we have one more Palmar space, that is the pulp space. Pulp space of digits. Okay, so other than this we have dorsal spaces. Okay, so those were Palmar spaces, and in the dorsal aspect we have dorsal spaces, which basically are the dorsal subcutaneous space and dorsal subaponeurotic space. Then we have a space of Verona. So when we see the mid-palmar space, so this is a triangular mid-palmar. So it is basically space here which we can see, which is located, okay, under the medial half of the hollow of the palm. So here if you see anteriorly, it is related to, okay, anteriorly we have the palmar aponeurosis. Okay, so palmar aponeurosis there, and then we have the superficial palmar arch here. So palmar aponeurosis is there, then the arch is there, palmar arch is there, superficial arch. So we'll have the tendons of flexor digitorum superficialis and flexor digitorum profundus tendon. Then basically the ulnar bursa, which will be enclosing these tendons, okay, flexor tendons of the medial three fingers. We can see this one. So here a bursa, that is ulnar bursa, will be enclosing this. Then we will also see the medial three lumbricals, because we are seeing the three flexor tendons there. We will also see the three lumbricals. So below that we have this space, and posteriorly it is covered by this fascia, which will be covering the interossei muscle. So this is the mid-palmar space, and laterally and medially it is separated by the intermediate septum here. Okay, so medially we have the medial palmar septum, and laterally we will have the lateral intermediate. This is the lateral palmar septum, this is the medial palmar septum, and this is the intermediate palmar septum. Okay, so it is bounded by the lateral, the medial as well as the intermediate palmar septum. Then okay, so proximally the mid-palmar space will be continuous with the space of Verona here. Okay, whereas distally the mid-palmar space will be continuous with the medial three web spaces. So between the medial three web spaces it will be continuous. So here it is continuous with the space of Verona. So infection of this mid-palmar space, okay, so usually what happens, the ulnar bursa. So in case the ulnar bursa is infected, which will be covering the tendons, the flexor tendons, right? So it acts as an inlet for the infection to spread. And so basically infection spreads to this ulnar bursa, and that infection can come out through the lumbrical canals. Lumbrical canals act as an outlet for the infection in the mid-palmar space. So from there, so usually we drain the pus, okay, they are drained by incisions in the medial two webs. So here we make an incision so that the pus is drained. Next we have a small triangular space here. This is the thenar space. Okay, so this is the thenar space now. So this is in the located in the outer half of the hollow of the palm. So here if you see anteriorly, we will form the again aponeurosis is there. Then digital nerves and vessels of the lateral 1.5 digit here. Then we have the radial bursa. So here we will see the radial bursa. Okay, so radial bursa will be covering the tendons of flexor pollicis longus. Then the flexor tendons of the index finger, we will see both superficialis and flexor digitorum profundus tendon, then flexor pollicis longus tendon covered by the radial bursa as well as the first lumbricals are seen here. So laterally there is the lateral intermuscular septa, medially there is the intermediate septa here, and posteriorly there will be the fascia which will be covering the transverse head of the adductor pollicis. So here proximally, okay, so proximally here it is fused here, okay, there is no space there because the anterior and posterior walls fused by the anterior and posterior walls in the carpal tunnel. But distally the space become continuous with the first web through the first lumbrical canal. So here the infection, just like how there the infection could reach to the ulnar bursa, here the infection can reach to the radial bursa, okay, and so the outlet will be the first lumbrical canal. So usually we make an incision in the first space, web space, and then release. So here web space of the thumb, we make an incision and release the pus, okay, infection. So this is the pulse space of the digits. Okay, so this space is what we see here. This is called the pulp space. So the pulp spaces of the digits, they are subcutaneous. If you see, they are just beneath the skin. Okay, and that is just on the palmar side of the tips of all the fingers. We will see the thumb and the fingers. So the pulp space, if you see here, it is filled with the fibrofatty tissue here, with the subcutaneous fatty tissue, and superficially the boundary here, it is bounded by the skin and the superficial fascia, and deep by the this is the distal phalanx. Okay, distal phalanx. So what I need to see here is it is traversed by many fibrous septa. Okay, so there are many fibrous septa extending from the skin into the periosteum. So it divides this entire pulp space into many loculi, many small spaces. So the deep fascia of the pulp of each of this finger fuses with the periosteum here. So if there is any infection, there is no space for it to expand because that is the deep fascia which is fused, and deep fascia doesn't have the elasticity to expand. So the pulp space infections become very painful. Okay, and here in this space we also see this digital artery, okay, which will be running. This is the digital artery. So this is being the most expanded part. What happens is the expanded parts of the digits, this pulp space, are more prone for infection. So an abscess in the pulp space, we call it as, okay, so if there is abscess occurs in the pulp space, we call it as the Whitlow or felon. Okay, so because of the rising tension, because of the pus getting filled there, okay, rising tension, the abscess increasing there, it causes very severe throbbing pain. So it is drained. So what we do, we make a incision along the laterally, we make an incision and we drain the pus. So here another thing what you have to remember is, so if neglected, the whitlow can cause avascular necrosis of the distal 4/5 of the terminal phalanx because of the occlusion of the digital artery here. And here another thing what you have to remember here is, I said only the distal 4/5, okay. Distal 4/5 is affected for avascular necrosis. But the proximal 1/5 is not affected. Proximal 1/5 is not affected. Why? Because it is supplied by the digital artery. Okay, the branch of digital artery supplying it will not, see here, if you see this branch which is supplying here, will not pass through the pulp space. Okay, it will not pass through the pulp space, and that is why it is spared. So the proximal 1/5 is spared because the digital branch supplying that part is spared because it doesn't pass through the space. Right, so that is about the pulp space. Then we have the space of Parona. So space of Parona is located here. This is the Parona space. So here the boundaries, here anteriorly there will be tendons of flexor digitorum profundus and flexor digitorum superficialis, which is surrounded by this synovial sheath. Then we also see the tendon of flexor pollicis longus. So proximally, okay, so proximally it will be continuous with the intermuscular spaces of the forearm. So here intermuscular spaces of forearm, it becomes continuous. Distally it reaches up to the level of the wrist. Okay, so here it goes up to the wrist, and laterally it is related to the outer border of the forearm and medially the inner border of the forearm. So this becomes infected. Okay, so whenever there is an ulnar bursa infection, from the ulnar bursa the space of Parona can be infected, because we learnt just a while before that the ulnar bursa communicates proximally with the space of Parona. Okay, so here we see, so this is the ulnar bursa. So when we see the ulnar bursa, it covers all the flexor tendons and it is continuous with the tendon of the little finger. Okay, but here it becomes discontinuous to the middle three fingers. Okay, here it separates. Okay, so it doesn't extend up to the distal aspect of the, up to the distal phalanx, it doesn't extend. Here it is separated, but only to the little finger. So if there is any infection in the little finger, it can spread all along to the ulnar bursa, and from the ulnar bursa, so the infection route can be from here to the ulnar bursa to the space of Parona, and from here to the radial bursa. So that is how the infection can spread. But if the infection occurs in these spaces, it is contained here itself because it doesn't communicate with the ulnar bursa. Whereas radial bursa here, from the ulnar it can go to radial. So radial bursa, this is the radial bursa. So radial bursa will be covering the flexor pollicis longus tendon. Okay, so here, so down here, this is the space of Parona. Okay, so ulnar bursa, all the flexor digitorum profundus and superficialis tendon, ulnar bursa, radial bursa will be flexor pollicis longus. So coming to the MCQs, the muscles highlighted that brings the digits towards the midline, the third digit R, the adduction pad, no, Palmar interossei is adduction. Which combined movement is produced by the labeled muscles? Okay, so these are all the lumbricals. So lumbricals bring about flexion at the metacarpophalangeal joint and extension of the dip and pip joint. So flexion at metacarpophalangeal joint and extension at interphalangeal joints. Yes. The deformity shown is most consistent with injury to, so it is here claw hand So ulnar claw head, so ulnar nerve at the breast. The label space most commonly receives, okay, so this space is infection from mid-Palmar space, so infection from the medial 3 lumbrical canals. Okay, so actually from the ulnar bursa it goes to that, and then from the lumbrical canals it is the outlet actually. Okay, and the boundaries of the infected space, so here it is infected, are all include all except flexor tendons of index fingers anteriorly, adductor pollicis posteriorly, first lumbrical medially, interossei muscle posteriorly. Yeah. So this is basically which space? This is the thenar space infection. Okay. So thenar space anteriorly there will be flexor tendons. Adductor pollicis tendon is there posteriorly. Yes. First lumbrical, there is medially, it is the intermediate septum. So those will be the boundaries. So the right answer will be the first lumbrical medially. So that's a wrap on today's session on the palm. So this revision series will bring you one step closer for your NEET PG dreams. So stay consistent, stay focused and trust in your preparation. I'll see you in the next session.